Good. Well, I'm happy to step in quickly. This is, I try to keep up with Martin with showing pictures of my children, so I just want to identify what I was tasked with was identifying barriers to lateral surgery adoption, and outlining enabling technology, and then look at future development and future cases, which I think is a pretty, I may go over some things that people have looked at, but the reality is I think the barriers to adoption of lateral is sort of a really important piece, but it boils down to a certain set of things that you can really tackle pretty easily. Number one is anatomy, which we'll look at. The anatomy is really simple. It is not complicated, even though the picture that, who showed that earlier?
All the blood vessels.
I think it was Rod showed a picture of earlier with all this stuff in the retroperitoneal space. But it's something you can manage. Complications, I think, are the things you really have to think about, and how can we manage those and the difference between those two, and especially hip flexor and the pain that we talked about in the psoas muscle. Technology and equipment we're short of navigation and robotics. This is standard equipment that is in every OR. And then the learning curve, as people always talk about. I took out my slide on the learning curve to do that, but the reality is it's just about an 80% learning curve. We talk about learning curve like it's something unique to medicine and surgery. In fact, it really started with the assembly line at Ford, figuring out how many cars they could make per hour when they started. And we're no different than people working at the Ford plant, wherever it is, assembling cars. The reality is our learning curve is almost identical. It's about an 80% learning curve. After about 10 cases, your timing improves significantly. I would tell you that the reality is after 1,000 cases, you're better at 1,010 cases than you are at 1,000 cases. It's just your rapid improvement tapers off quite a little bit. There's actually some really good work on that. If you're interested at late stage in career, like 1,000 cases, you think, oh, I'm done learning. But the reality is if they look at it, and the work was done in prostate surgery with urologists, the patients do better after they've done 5,000 than after they've done 3,000. So there is learning that happens, but it tapers off. I just think the cartoon in the bottom, you really got to ask what you're looking for, right? If you're going for a hike out in the woods and you don't see the Eiffel Tower, don't be disappointed. Minimally invasive and lateral surgery is you have to be realistic about what you can do. This, I think, is what I stole that from Roger Hartle. I think it is nice because you have to figure out not just where it fits in traditional open surgery and minimally invasive, but where the benefit is and where the benefit is in your practice, because every practice is different. What I found is what Martin does, even though we sit in the same office every single Wednesday, his patient population and the people he sees and the surgery he does is different than what I see. And so I just encourage everybody to figure out where that benefit is. And in some ways it's not exact, but I do think you're going to find that out. So anatomy, we'll talk about a few things. And remember, the anatomy of the retroperitoneal space, and I turned the top one is sort of, as you see an MRI scan, the bottom one is prone. Remember the ascending colon in the within the space, and then the descending colon within the the opposite way around. You got to remember the vessels that are in there, psoas muscle, and the lumbar plexus within the psoas muscle. I think the most important thing is just to know that the retroperitoneal space is a potential space that people use all the time to gain access. And if you look at that top picture, remember, it's not just psoas muscles you're looking at. The vasculature, as you heard beforehand from Louise, if you're looking at is this a transition level or not, think about the vascular structures rather than just trying to look for nerves or psoas muscle. The vascular structures are really the tip-off. And then the musculature is really important too, especially when you're talking about doing something prone, how to safely access that. And that's really finding the quadratus in the back there. And instead of going right for the psoas muscle, palpate the quadratus, depress the peritoneum, open the retroperitoneal space as access to there, which I think is really, really helpful. Vascular structures, again, know where the bifurcation is, middle sacral vein, know where the vessels are in that spot, and especially down at 5-1, you can see the vessels, you can see the psoas muscles have exited, and this was leveled down at the bottom. I always show that. That was called 4-5 because of a transitional level. It's a herniated disc, as you can see, but they called it 4-5, and it's clearly not. So your responsibility for the lateral is not just identifying, but to know the anatomy. And this comes from Juan for the trans-psoas and the approach. These are not flat structures, remember? This is a 3D structure. The genitofemoral nerve and other things are on the top of the psoas, and the ilioinguinal hypogastric run in the layers of the abdomen. So that's why we do blunt dissection. But if you have a good idea of what you're looking at with the lumbar plexus and what you can stimulate and what gets better, I especially like the psoas talk that we heard earlier. The reality is people forget there's not a named nerve to the psoas. It's ventral roots at every single level. So if you dissect across the face of the disc space, you're going to get the ventral roots from that level, and that's often why you get atrophy and often why multiple levels are a problem more than just manipulation of the psoas. So safe and easy access should not be a barrier to approaching. Again, we're talking about prone. Blunt dissection is critical to avoid the ilioinguinal and iliohypogastric nerves, which run in the abdominal wall. And you can bluntly pass your finger in there as again, Dr. Pimenta and Juan talked about. So palpate the quadratus and then locate and push the perineum down. And again, I'm sorry that everything I do is prone-centric now, but these techniques will do whether you're in the lateral position or whether you're in the prone position. So plan where your incision is. Where your incision is, you can easily navigate that. You can get depth from that navigation, which is nice to plan beforehand, and make sure your patient's secured. In the prone, you're using a frame. So the first thing I do is palpate the quadratus rather than dissecting through. Sweep downwards, open up the retroperitoneal space. And there are 3 things that I make the residents do to be sure we're in the retroperitoneal space, whether you're doing a lateral, whether you're doing a prone, whether you're doing an LLIF, whatever you're doing is you palpate the undersurface of the iliac crest, the transverse process and the psoas muscle, and underneath the rib. If you can palpate all 3 of those, you're definitely in the retroperitoneal space. And I always say the same thing. Retroperitoneal was like someone's definition of pornography. Can't describe it, but I know it when I see it. And this retroperitoneal space, if you can't describe it, you know it when you feel it if you're doing it bluntly. So make sure that you can feel all 3 of those, all right? And then I dock at an appropriate location and place the retractor, which we sort of talked about earlier. For me, is level dependent and because of the location of the plexus. So complications, again, we sort of looked at it before. I think over on this side, we always forget because we're focused on nerve and vascular and abdominal complications is LLIFs have complications with nerves too. They have vascular complications which are higher and less so abdominal complications, probably because we have general surgeons or vascular surgeons doing it. But people always forget about, they say, well, I do a TLIF because I don't want to risk those other complications. But the fact is a posterior TLIF has nerve complications, vascular complications, abdominal complications too. And again, the nerve complications are really not that much different from the lateral approach by the time you figure in foot drop and other things in compression. But the real difference is this: poor correction, higher subsidence, increased infection, increased CSF leak, and pseudoarthrosis. And people forget that because they don't really have that problem. And we don't have a problem. And Martin does 10 LLIFs a year. When's the last time you had an infection? I just had one recently, so I want you guys to realize that doing it lateral. But it's not a common thing. And so we forget that when you're doing all posterior surgery, that's a real big complication. I don't think we should forget those things. I would say that lateral position, again, slightly higher pedicles group reach rate if you look at the single position lateral. But don't forget about all the things that don't occur when you have that. And if someone tells you, well, I've never had a nerve root injury when I do a posterior TLIF, then you really should not be listening to what they have to say. But each one of these have their own issues. And I think it matters. It matters what where you are and who you have to work with. So this is just the hip flexion weakness. Remember, those run along the face of the psoas. They run obliquely. The more levels you dissect, you can't test for them. There's no neuromonitoring. You can't visualize them. They're small, mostly unmyelinated nerve roots that go directly that, and they're one of the first branches. So unfortunately, I think this is just what we're going to get. The idea is that it doesn't matter whether you go transpsoas. It doesn't matter whether you dock on the anterior part. This occurs because of the interaction between these ventral roots, which run obliquely in all those locations. And the more levels you do, the more likely you are to get multiple of those branches. So the thing that we sort of talked about, enabling technology, where do we sit? Again, neuromonitoring, I think, is absolutely critical, especially if you're doing prone, and especially if you're putting in pedicle screws. The reality is it's not that easy. I had someone ask a question last week in conference, said, well, I know Martin was there, was one of the orthopedic surgeons, said, well, what's your number of pedicle screw when you test that is going to be a problem? And the reality is, once again, it matters if you're at S1. It matters you're at L2. And you could have a lateral breach and still test perfectly fine at the upper levels because you're not in contact with the nerve root. So the neuromonitoring needs to be interpreted. Robotics, I think, is great. Navigation is much easier. Patient positioning is critical. Patient positioning is critical whether you're doing this in the lateral or prone, because you really have to have access to what you want to do. And you've already heard a couple people talk about, if I'm using navigation, where do I put my retractor? Where do I put the PSIS pin? I don't want to be fighting with myself. How do I keep the navigation working properly? I also make a comment on navigation is, if you're using navigation, it is not a failure to bring the X-ray machine into the room and do a fluoro occasionally. You've just saved yourself a lot of time, a lot of takebacks, and a lot of radiation. All of a sudden I hear these people, well, I was using navigation, but I'd have to bring the fluoro machine. It's like, who cares? Bring the fluoro machine in, spend 10 seconds getting a good X-ray at the end of your case so you know where you're at. It's not a failure. And then pre-op planning. I just think we've got to, people have an algorithm in their head that they want to do. And I think, again, you got to listen, why are you doing the surgery? What level are you at? And where are you doing it? And you see all these great things people putting on Instagram. I always worry about, people that tell them they do a 10-level fusion and they discharge the patient the same day. I also the learning curve we talked about, I've heard a lot of famous spine surgeons, very, very well known, who said, well, you should do what you do best because that's best for the patient. I just think that's an excuse not to learn anything new. And I think that's an excuse for people to just keep on doing the same thing because they don't want to do anything else. It's a lot of work to learn something new, especially when you reach my advanced stage. So it's a lot easier when you're in residency. And I really dislike hearing people stand up and say, well, the best surgery for the patient is the one that I do best. Well, your colleague down the street may have a better surgery, and I worry about when I hear that from someone, and I think this is one of the things we really need to work out against. Neuromonitoring, intraoperative modality, multimodality is the key thing in neuromonitoring, right? Use all the facts you have. Triggered EMG, free run EMG. The clinical EMG doesn't change. That takes about 6 to 8 weeks. SSEPs, MAPs, and then for us, certainly saphenous SSEPs. EMG is not enough when you're doing a lateral surgery if you're going to dissect through the psoas or retract at all. There's absolutely no reason not to use SSEPs. I also tell you that, some of that didn't project. Sorry about that. There's a couple studies looking at time. We tried to repeat this with a pig study and couldn't do it as well because I really wanted to get the lumbar plexus and the size of the nerve root I thought was important. This is a tibial nerve, which is really small. But the reality is time matters when you're retracting the nerve. Venous congestion, venous hypertension, relative ischemia, and as time goes on, it gets worse. But it is not an absolute number. If you hear people start talking about, well, if I do the surgery in 20 minutes, I'll be perfectly fine, that's nonsense. You could do a surgery and take 5 hours and the patient would be fine. What matters is that individual person. Time does matter though, but it's not an absolute number. But certainly the faster you work, the less problems you're going to have. So I would tell you, Saphenous SSEPs are great for doing that. Automated femoral nerve monitoring. It's really, really hard to get a false negative with reliable saphenous SSEPs. They don't, really, the studies show if you never have a problem, it's so rare for people to wake up without a deficit. And I have actually found that it's very sensitive and it's specific. And you really want to think about multimodality, correlate where you're at, but the saphenous SSEP automated monitoring is something you really need to pay attention to. The longer you do the surgery, the bigger the problem is. And this is just really just telling you that it's really difficult with saphenous SSEPs to wake up with a deficit that didn't show up in some way on the neuromonitoring. And I think it's a really, really great thing to follow. The other thing that's nice about neuromonitoring is if you remove the retractor, if your saphenous SSEP has dropped, then it's very, very good news when it comes back to normal, okay? So again, it'll return back to normal quickly and it'll give you an idea as to whether you're gonna have a problem or not. This is really a plug again for robotics and navigation, especially in the prone position. You've seen the pictures down there before of docking and the opportunities you have. The bottom picture there just shows you how hard it is to really angle the retractor. With fluoro, you really need navigation. And the reality is this is just a study. It was an AO study that I ran into with a database they have. The reality is if you're not using navigation in some way in the countries that are in sort of orangish there, you're really behind the times. Robot assistance is much, much less. So the reality is people have found navigation to be more helpful. The robot is still not as well used as the navigation piece. But the navigation piece, especially when you're talking about lateral, allows you to see the vessels, allows you to see the psoas muscle. Now, neuromonitoring gives you an idea of where the lumbar plexus is, and it allows you to work in that space very, very, very safely. And so I really think you need to do it. Again, prone, what do I like about the prone position? I didn't show this slide before. Surgical planning with coronal bend, being able to increase your correction for scoliosis, reduce abdominal issues, the anterior perineum falls forward, familiar, fast, easy, safe positioning, increased lordosis, and then simultaneous access and posterior plexus. All of those things make it better. So enabling technology, this is someone else's case. I asked someone, I don't remember who it was now, I said, hey, can you send me an expandable cage case, because I don't do it. But lateral expandable cages are an enabling technology for what people are doing. So the reality is it's very accessible through the lateral space. This is someone bilateral PCOs, which if you're prone again, very, very easy. It's not a roadblock to do anything posteriorly. There's no reason you can't do lateral, flip the patient. I actually have in the past done just exactly what you saw before with a multi-level case, come back another day and see what's going on posteriorly. But expandable cages are great as an enabling technology along with navigation. And then it's sort of future things. We've already had talks about corpectomy. The reality is the corpectomy case are great cases to do for these people. Very easy access and look good when you get done. There's another case which I think just looking at odd cases that people do, a spinal shortening case with a tethered cord. We have done a couple of these. If you have patients in your practice, as we have a big pediatric practice that have had a couple release of tethered cords, this is something that's really nice to be able to do, a spinal shortening. We usually do it at the T12 or L1 level because it's actually loaded. So you can very easily do a partial corpectomy, transpedicular corpectomy posteriorly, place pedicle screws, continue with the anterior corpectomy in the lateral approach simultaneously, posterior rods, and then compress through that area to be able to give yourself a really good chance for a spinal shortening case. And this is just the picture posteriorly where you can see the rod in place and you can see where we are. This is the lateral picture. This is the corpectomy we did in the green line and then closing off the corpectomy at the end. with a complete resection of the bone. So future directions, I think we're going to find other things to do with the lateral approach, corpectomies, and you're going to hear about a lot of deformity. And this is the procedure afterwards, where sort of bone sits on bone. Thoracic disc cases, again, prone thoracic disc cases. This one's especially good if you see the top screen. You can see the patient had both posterior and anterior compression. Doing this prone allows us to do the laminectomy posteriorly. It allows us to do a decompression, pedicle screw fixation, and do the anterior approach at the same time with a discectomy. The far right picture is the retractor with the discectomy in position there. And we already had a talk about removing the rib head and everything, which is easily done through a small incision. But as you start to look for things, this is not an uncommon finding where you think, oh, I've got to do a posterior surgery at the same time. So you're not supposed to put disclosures down, but my disclosures are really that I'd rather be here, and I'm not here to take away your surgery that you like and that you're married to, but I really want people to start thinking about patient-centric approach. Why am I here? What am I doing? What level am I at? Where am I operating? And I think you're going to find that each of these procedures will fit into your algorithm very, very well. Thank you. Sorry. Go ahead, yeah.
Hey, so outstanding work and great summary lecture. Speaking to the prone surgeon, is there a circumstance where you'd see going bilaterally? So patient is prone, you're doing your posterior part?
Yeah, it's kind of funny you asked that, because there's someone that I work with, and it's Roy Ashtori, who's up in San Francisco, and he has talked about going bilaterally when he's got a scoliosis patient. Really where he thought he couldn't get into one level from one side or it was difficult. So he has done bilateral approaches. Seriously? I have, seriously. Yeah, I have never done a bilateral approach.
For the record, that's ridiculous.
Say that
again? I
again?
put this on tape. For the record, that is ridiculous. I really do not believe we should be supporting it.
Yeah, crazy. And I'm telling you, that's what I'm saying. I have... Okay. So what I was going to say is I have never done it. Wow. I don't recommend it, and I wouldn't do it. But if you guys want to do it, it's up to you. I see absolutely no reason to do it. I've never done it, don't plan on doing it, and wouldn't recommend it. Yeah.
Nope.
Any other questions? Yeah.
So do you find your confidence in the saphenous SSEP allows you to spend more time when you need to?
Yes.
Because at least for me, I've triggered the alert probably 12 times in 200 levels of this, skewed early on, and I've always closed the retractor or just hurried up. Unfortunately, not had like a big problem with it, but it does help me to be more careful. Like I had a nerve plastered over the disc space a couple weeks ago, and I spent 30 minutes kind of painfully scraping it out of the way. But I felt okay because the SAF SSEPs were good. But I don't know if that's too much.
Yeah, so I think there's a lot of questions in there, right, that we sort of brushed over. Number one, the automated stuff, the alert comes up at 50%. That's because that's been the traditional number. There's absolutely no physiologic reason that 50% makes any difference compared to 75% or 25% as far as we know. That's what the neurophysiologist picked in the beginning, and so people went with that. Does it matter? The answer is we know it matters, but we don't really know when, right? Nobody knows. Is 10 minutes at 50% the same as 1 minute at 75%? So none of those numbers are known. So I always caution people that these are done because of a long history with a different monitoring system and a different, neurophysiologist in the room. But you should pay attention to them. It's all we really have, but that number is not perfect. So if you're getting alert, you have to figure out how long is it into the case. The biggest problem that I've actually seen in my patients when I'm doing a prone is femoral nerve problems because of positioning. And that will come up on the saphenous SSEPs because it's part of the output of the lumbar plexus. So I find that to be the bigger problem.
You
but
usually see that bilaterally. Bilaterally,
usually. So you have to think about when do I see it bilaterally. The other thing I would tell you is the neurophysiologists who are doing saphenous SSEP monitoring are not as helpful as they pretend to be. Now, why is that? Number one, it's a very, very small signal. It's very difficult for them to navigate and monitor that and see any change. Number two, they spend about 10 minutes averaging this. They don't have rolling averages when they do it. So they do it for 10 minutes, and then they do it for another 10 minutes because they want to make sure that you really have something. You're up to 20 minutes by that point, and you're done. You're done with a level almost certainly. So it's really a difficult thing to do. So I use the automated one for that specific reason. I will do something in the short term. If I'm almost done with a level, I'll just keep on going. If it happens quickly and it's bilaterally, probably femoral nerve, anesthesia, some problem. If it occurs pretty quickly, I will often reposition the retractor. I'll decrease my retraction time. I'll lower it down because remember, if you look at the studies, it shows venous hypertension is the initial problem, right? So venous hypertension and then relative ischemia because you don't get as good a blood flow because it backs up. And so you have a recovery time. So the sooner you do something, the better chance there's not going to be a problem. But I would tell you it sort of matters what you find, when, and how terrible it is. There's nothing worse than someone who has absolutely no experience looking at the automated saphenous SSEPs and tell you, oh, it's dropping. It's like, and that's a really frustrating situation. That's the only thing I don't like about it.
I think the coronal bending is very helpful, but I take that off as soon as the lateral body's in, because I think that probably...
I do coronal bending, the pads, tweaks the psoas, I loosen up the pads, I decrease the retractor. It just buys you some more time is what it does. I don't know. What were you going to say, yeah?
So if you go to a PPT multi-level versus one level, where do you anchor your retractor? At the top or the bottom of your exposure cycle? So in other words, if you do want to, like say, for example, L2 to L5, you put your retractor, the anchor above?
Above. I'll put it above because I'm navigating and I made the mistake multiple times and I put it below and the arm seems to get in the way of it. So I always put it above. I don't know. What are you guys, Martin or Neil? Zach?
Yeah, I mean, if you're using fluoro, I would put it closest to the hardest level.
Yeah.
So it's usually 4 or 5. I want the least motion for you because it's not in the way of fluoro. But if you're nabbing, then you're going to have to be.
Yeah. Any thoughts, Martin?
By anchor, do you mean the post?
Yeah, exactly.
The post, yeah.
Yeah, I mean, for me, it's always to my left. Usually it's just closer for me to maneuver. And to Bill's point, it's out of the way of the navigation because it's lower profile. If you ever find your retractor coming up and over, remember there's enough joints to flatten.
Yeah.
Right? So, if some companies make a short arm already, which is nice, use a company that the arm is still long, just remember if it's coming up and over and dropping to your PTP, typically that joint on top you can flatten down against the patient's back so that it makes room for the neck. Great, thanks.
Yeah. All right.
All right.
Good, thanks.
I think